Well, happy Monday, everybody. I am delighted to welcome you all to our Lown webinar series. I'm Dara Lee Lewis, and my colleague Allison Kelly Hedgepeth and I are thrilled to welcome our colleague, friend, and mentor, Dr. Marie Gerhard-Herman, who is a vascular specialist and cardiologist at Brigham and Women's Hospital. She is my personal go-to for all questions about vascular problems and always has an answer, and a thoughtful one at that. And today she's going to talk to us about Raynaud's and beyond, and other things besides Raynaud's that can cause discoloration and coldness of the fingers and toes. So we have really happy to see a huge group turn out today. And we've gotten a few questions in the email, but we're welcoming all of you to also submit to the Q&A any questions you have as Marie talks. So Marie, welcome, and thank you so much for being here.
It is my pleasure. And as I set this up, I have to tell you, I learned a lot about the fact that a lot of people don't know about Raynaud's. I did a discussion with someone from NBC last week, and it was actually quite striking. So I tried to back this down a little bit, and if I do too much science talk during this, you guys are going to tell me. But we'll try to make things clear for everyone. So I used the title that Dara had nicely bestowed on me, Why Are My Hands and Feet So Cold? Raynaud's and Other Disorders of the Circulation. I believe I have no disclosures for this. All my funding is NIH and PRF. So everybody's fingers and toes get cold. So there's normal arterial function that requires dilation and constriction. So if everybody goes out in the cold from their warm house, they're going to get cold fingers and toes. That by itself is not Raynaud's. Raynaud's is going to happen when that arterial blood that got to the tip of the finger or the toes is constricted from being there. And that happens through a nerve innervation mostly. And how much constriction depends on what the health of the vessel is that's being told to clamp down or open up. We can look at it kind of simply in the areas where these receptors are concentrated. So they're fingers and toes, which we all think about. There's also tip of the nose, earlobes, particularly in the Northeast for some reason, and tip of the tongue. So blood gets shifted away from the extremities in the setting of cold, and that's a normal response. The idea is to shift the warm blood into the core. If there's vasospasm, there's more vasoconstriction than you actually need in that setting, and adequate blood flow doesn't reach the finger or the toe. So simple things like this waveform, putting a pulse ox onto the finger, showed that it's not the usual cardiac ejection pattern, which would be something like this. Instead, the ischemia episode occurs, and what happens is people have a feeling similar to like a tight string being wrapped around the finger or toe. Blood flow has been cut off, and the finger gets numb and cold. And to people that don't have Raynaud's, I think one thing that people forget about is you can't actually use your fingers, and you can't walk normally when this is happening. If that was going on all the time and not in episodes, then you worry that there's some fixed blockage to flow to the toes. This is a little complicated, but this is a big nerve coming in. So the nerves send lots of signals to the muscle in the artery wall and tell it whether to open up and let blood go wherever it's supposed to go or to close down. And some of those receptors are going to have individual importance in different phenomena that we're going to talk about. So clinical vasospasm has a lot of phenomena. So the CGRP that I just showed you is probably up front and center in migraine. Variant angina, which is a kind of chest pain that doesn't necessarily go with activity. Raynaud's, which we'll spend a fair bit of time on. Intestinal angina, we're going to touch on briefly because it's part of a story. Acrocyanosis is mostly seen in children. Livido is a very important signal for all of us to recognize, so I've included in the talk. erythromelalgia, and something called peritoneal or chilblains, which is going to be very important this time of year as part of Raynaud's and as a separate phenomenon. And the reason I'm presenting it like this is these things are all connected. Nothing is completely separate. Just like the blood vessels are connected, all of your body, bringing blood from the heart for the arteries and then back to the heart with the veins. And I think we all need to remember, as human beings, when someone treats one phenomena, they're going to affect other phenomena in the human being. So we have to know. So one thing we do is we're thinking about the fingers, and they're getting episodically white or blue and cold. We want to know what kind of blood flow is getting to the finger. And we have a simple way of putting a cap or a band around the finger and looking what the arterial flow looks like. On the right would have been a normal arterial waveform. That's the cardiac ejection and then the rest in between. And that's how the blood is normally carried in the vessel. But on the left, you see this cold white digit initially didn't have that. Very blunted flow to the digit, which was improved with warming. More importantly, since the advent of iPhones, is pictures that people have where we see this clear demarcation. And I have the beach. This person was just in the water and they graciously let me take their picture. But you don't have to be on an icy cold mountain to have Raynaud's. Anywhere where you're going from hot to cold to hot, those changes in temperature are going to cause these vasoreactive responses. So this person came out of the somewhat cold New England ocean water. And it wasn't Michael. The fingertip is cool, well demarcated, and it can be white or blue. Classically, they show you these pictures, and a lot of your physician friends will get stuck on like, what order does it go in? White, red, blue, blue, white. It doesn't matter. So when blood flow is cut off, the fingertip gets white. As those the blood stays there, it gets more deoxygenated. It gets a little more blue. Then when you warm the digit up, the person up, usually the digit up, blood pours to the fingers or the toes and they turn red. These are the most flagrant examples, but there are many, many possibilities. And this is important for this audience. So there's the majority of Raynaud's is going to be primary. So it's Raynaud's that starts in the teens. And what the individual notices is that when they're out in the cold, their fingers or toes are going to get white and cold and numb. And the rest of their hand stays at their usual color. It doesn't happen to all their friends necessarily. And they start to modify their activities around that. That is more prevalent as you go from the tropics to the Northeast. But by the time you get up here, it gets to be about 1 to 5. And then the nice thing about primary Raynaud's is it by itself doesn't result in some of the bad things we worry about with blood flow being cut off for too long. There's no ulcers on the fingers. They don't actually stop blood flow for long enough to lose their digits. Dara, you'll read the chat for me if it's important to know while I'm talking, but otherwise I'm letting it alone.
Yeah, we're good.
The other thing about primary is no one knows yet what kind of genetic influence there is on primary Raynaud's phenomenon in families. But there is some data coming out now. It's very preliminary, but it suggests there are possible genetic reasons for Raynaud's phenomenon. And most of the genes that have been identified affect those nerves that are giving the signals to the arterial wall to constrict. I know as a clinician, I definitely see familial patterns. So it's going to be true at some degree. Secondary Raynaud's phenomenon is most, I would say 70% is from collagen vascular diseases. Scleroderma is the most concerning because people get the Raynaud's phenomenon for about a decade before they get the scleroderma. And other collagen vascular diseases, they have evidence of that disease. And there's another trick I'll show you for how we figure out if that's happening. If you have some reason that blood flow is being cut off to the finger, like atherosclerosis or something else, you can get Raynaud's, because a normal signal to constrict being appropriately interpreted will still cause overclamping because the pressure to the digit is lower. I didn't put it on the slide, but the concern with secondaries, you can get ulcers and you can get digit loss. So we try to jump on that with both feet and help people. We're not going to stop here, but hopefully this will be in an archive for you, because there are a million reasons for people to get Raynaud's. On the left in blue, I put connective tissue disease because that's what people think about. But drugs, particularly Adderall, shifts in estrogen, occupational exposure, chemotherapeutics, thrombocytosis, or diseases where your blood gets thicker, and anything that affects the nerves coming out of the spine is going to cause Raynaud's. So we do, this is also too complicated for the moment. I'll break it down for you, but we do have a systematic way to look at that huge thing I just showed you. And it really starts like this. First, we define that the person actually has some kind of cold sensitivity, where they have a change in color that when exposed to the cold, that goes away when they get warm. And if they have pictures, it's incredibly helpful. You know, decades ago, we didn't have pictures. It was harder to make this diagnosis. It's very easy now. And then history is huge. Of course, as in all medicine, talk to the patient and you learn about what's going on. There are a lot of causative factors. Our examinations always include maneuvers for thoracic outlet and looking at the flow to the fingers with just putting that pulse ox on that's in the exam room. And the other thing we do is look at nail fold capillaries. This is a little bit overdone, but it's to give you the idea. Normally, nail fold capillaries should be like a picket fence of lines, the bottom of the nail. And we don't usually see them without using some kind of magnification. I have a quick and dirty trick I do where I push down to make the fingertip all white, and then I see if there's any spots that show up. This was one of those. But that tells you there may be some type of collagen vascular or rheumatologic disease going on. It's not 100% though. So we do a lot of lab testing. Let's see. What do we do about it? The big thing, hopefully you all got the handout that we give patients, because it's much more detailed than this, but this covers a lot of it. Warming to limit vasoconstriction is huge. And that's warming that is central warming. The neck is a big trigger for vasoconstriction. The head in general in the winter. And there are things like thin slate, heat tech, other kinds of warm clothing to put on. Stress is huge. And we're going to go over that in the end, but stress is huge in provoking Raynaud's phenomenon. Any kind of sympathomimitic is bad. And we always have to walk backwards and find out how much coffee is being consumed, because if anybody's drinking more than 1 cup of coffee a day, that's absolutely able to trigger bad Raynaud's phenomenon. And sometimes people had been moving along with primary Raynaud's phenomenon and not really having a problem. And then someone put them on Adderall, or they took a new job, or they're working nights and they're starting to have like 6 cups of coffee a day. So just tease that out. But any of those sympathomimetics are going to trigger this. So primary Raynaud's phenomenon is usually treated with a calcium channel blocker. And we have many options for secondary Raynaud's phenomenon, including SSRIs for people who have low blood pressures, but they're very good for some of those nerve blood vessel exchanges. For bad cases, we have sympathectomy, typically with Botox, and then with microsurgery at this level. It's harder to do in the feet. And we have Valitree or treprostinil at the moment. Hopefully we'll get more. The other thing about vasospasm, and this is good for thinking about triggers, is this. So this is livedo reticularis. I don't have any, or I'd stick my arm up, but it's easy to look at on yourself. If you're not wearing anything over your knees, the knees is one of the places it first shows up, is why I pointed there. And it's just a lacy pattern, a red lacy pattern. It is definitely a marker for overinterpretation of the signals to vasoconstrict. And it also is a marker for how much stress is contributing to the overall situation. So it's a certain part of the vascular cascade here at the arterioles that gets this response to oversignaling. And most of the time, it's because of stress, or there's 75 cups of coffee. But you can tell by just pushing down and seeing if it goes away. So that's blanching, or, putting the arm up like this and seeing if it goes away. If it doesn't go away and is fixed, then we worry about vasculitis, which would be incredibly rare to see. Most of the time, this is primary Raynaud, primary libido with primary Raynauds. And the patterns are typically like this with reticularis. These other two patterns make us start worrying more about something like vasculitis. So pernio, also I have a million pictures of these, but this discoloration has this sort of brown, yellow, violet look to it. These lesions will come out in the cold and they'll stay like during all of winter, and then they'll go away. And they don't have to be this dramatic. It can be barely a blush of a spot. But the key about pernio is that you'll feel like you're being stabbed with a needle before you see the lesion. So that lets us know that it's pernio. Those lesions are itchy. I call them yellow-violet. They're pretty flat. And they're there all during the winter season. And it causes a lot of pain. So the appearance is one thing, but the pain can be disabling for people. These are lots of examples, and we saw more of these during COVID, and it was associated also with Raynaud's. Families with who get pernio and Raynaud's and libido together every time they get a virus. So all these things do travel together, but you can see how subtle these lesions can be. When there are pressure points, you really want to know that they have them at other places as well. But the key to them is that they have this very painful onset. If they're sort of flat and spread out and have like creepy looking borders that look like they're migrating around, you want to bring that to your attention of your doctor, because those would be unusual, but you would start to think about other things causing them, despite the usual cold effect on the complement, in the complement levels in that population, specific complement levels. Chemotherapy, this is really a black box area, but if you're receiving chemotherapy of any type, and you're noticing white or blue, episodic or non-episodic extremities and digits, you need to talk to your doctor. There's a lot of medicines that can be involved here. Some cause Raynaud's, but a lot cause disease more proximally as well. And the thing to look at, so this is blue toes, and they're cool to the touch. We did put warm blankets on, and we got the color to change back to white. So that tells us it's vasospasm and not fixed disease. If it's fixed disease, it goes on for a long time. Blood flow gets cut off to the digits. And here you see tissue begin to die or necrosis. We absolutely want to not fall into that. This was a sad one, as you can tell by the hospital bed, because it started with episodes that they let go on for too long. Now, the other one that we need to know about, because they all travel together, is erythromelalgia. So with erythromelalgia, people have episodes of red hot feet or hands. And it's burning pain that is really only relieved if they like stick their hands or feet in a bucket of ice. I've one of the first people I saw with this, probably 35 years ago, actually came in with her bucket of ice. In these cases also, it's if you can push and it turns white, it doesn't stay red, it's primary. If you can't, it's secondary, and that's often related to different kinds of myeloproliferative disease with predominance of polycythemia vera. So those myeloproliferative diseases with increased numbers of cells. And that's also a reason they could swing back and forth between Raynaud's and erythromelalgia. So these are some examples. You can see it can be fairly subtle, like in this case. They look red, doesn't look horrible. To this case, where it's just incredibly red and hot. He also had Raynaud's with this, and he had these funny lesions, which we biopsied, and he had Dagos disease, which is an unusual thing that can cause erythromelalgia. He was treated, you can see the color changes got better, but it actually had caused another kind of vessel to vasospasm, which was lymphatics, and initially caused some lymphedema, and that got better. And this got better too, because these were ulcerated before and they're healing. Lymphedema, if you have a swollen leg, is picked up when someone cannot pinch the skin on the back of your foot and lift up the skin. Let's see if I can show you like that. So you should be able to lift up the skin on the top of the foot. Main thing is to limit triggers. If there's a secondary cause, you're going to treat it. And topical lidocaine works. Prozac or fluoxetine work, as do others in the SSRI category. High-dose aspirin, not so much, but it's got a historical punch. Alpha adrenergic blockade turns out to be great because it works on both the Raynaud's component and the erythromelalgia. It's not always clear, and there are unusual situations like clusters of mushroom poisoning in China and things like that. We look for autoimmune disorders, but more likely is a small fiber neuropathy, polycythemia vera, and potentially it's the first thing when they get their cancer as they show up like this. Sometimes people show up with Raynaud's in their 40s, 50s, 60s as the first marker for their cancer, and that's typically a breast cancer. So this artery story is interesting because this is someone who is just racked with discomfort from her arterial problems of many sorts. So I wrote this out in clinic for her, trying to explain what the arteries do and that the nervous system actually signals the arteries. And she did have rheumatoid arthritis. That is, it could early on change the way the arterial walls are. And just showed her all the places in her body that were being affected by the arteries being narrow, as in this blue. So she had Raynaud's of the fingers and toes, and she had an intestinal Raynaud's. She also had erythromelalgia. I'm trying to show you heat on her feet. She had migraines, and she had livido everywhere. She did have underlying dysautonomia, which may be treating to this, leading to part of this. And she had a big traumatic childhood background, which is going to be a problem. We were able to move forward, and we tried to make it easy for her, saying that the simple things like walking daily, drinking water, and recognizing your stress signals and acting on them will tilt the arteries towards staying open. And we talked about medicines. She had one, Amuvig, that was making it worse. We talked about things that can make it better. And I'm going to take only 1 second here, Dara, but stress, when I say this, sometimes patients say, I'm not stressed, which could be a sentence. But in my parlance, I'm using it as stress is the body's response to anything. So if my pager went off right now, I would have an increase in adrenaline and cortisol as a response to stress. My pager goes off right now and I take a deep, slow breath while I'm talking to you. That's going to decrease the impact of that adrenaline and cortisol in my body. Can also think about stress in terms of stress as the stress response or the fight, flight, or freeze. When you're in fight, flight, or freeze, you're definitely going to be increasing up adrenaline along with other things like cortisol, and you're going to be causing peripheral vasoconstriction. This is just, there are simple ways, I don't know if it's going to play or not, where we teach people very briefly.
Fabulous.
This is actually on your phones, etc. So it's a way to look at it. And there are stress warning signals. I can get this to Dara and Allison to send to you all as well. That if you recognize beyond just cold fingers, which I have at the top of the list, because clearly it's relevant to what I do, but other stressors will have warning signals when you're having a stress response, and you can start to tone it down with breathing, which is going to help. I'm going to stop there because I wanted to leave lots of time for questions, and I'll get out of here.
I don't think anyone caught that you were just showing an ultrasound that looked like a little face. Is that right?
Oh, yes. Just veins in the legs. It looks like Halloween to me.
It does. It's very timely. Marie, that was fantastic. And so I think for the audience, so some of this is definitely kind of the type of thing we would teach our trainees, right? Doctors to learn and pictures to look at. And hopefully you all were able to follow that, because it's really important to understand why it is that the fingers turn white and then why it is that they turn red. So thank you for helping us understand the physiology and pathophysiology behind all this. It's great.
I tend to talk to patients the same way I talk to other doctors. So I often need a translator, so you guys can feel free to ask me to translate.
That's why your patients love you. So there's some questions coming out, and I am going to start with this one. Would you discuss ulcers more? For example, a bump showed up on my finger, it turns white. I don't know if it's an ulcer, it doesn't go away.
I wish I had a picture. But ulcers is going to be anything that damages the skin. And when it's an ulcer on the finger and it's related to blood flow not getting there, it's going to be at the distal part of the finger. Ulcers will have a different kind of pain. It's not going to be that stab pain of pernio. They usually erode and have a little serous fluid as well. So white is throwing me off because a white lesion would not necessarily be an ulcer.
It's usually going to be like a little bit bloody or pussy or broken down skin. Yeah, yeah. White would be different. Okay. Thank you. Okay. Here's another one. In addition to symptoms of Raynaud, sometimes I get shiny hands that feel tight, severe discoloration of my fingers when I carry cold groceries or shopping bags in my hands. The color does return to normal after a while. Should I be worried about scleroderma? And if so, what blood tests can help for this?
Yes. So particularly if this started after you were 30 years old, or if it got dramatically different after you're 30 years old, I would worry about scleroderma. Because as I said, scleroderma is the one thing where your Raynaud's can show up 10 to 20 years before the scleroderma. And the earlier we know, the earlier we can treat both aspects and make it better. On exam, in terms of shiny, they should also be sort of sausage digits. And one tip off for you would be as if your ring size changes, so you can no longer remove rings. We'll do similar kind of experiments looking at the flexibility of the skin in the finger to tell. And then there's a scleroderma panel that your doctor can order.
So just to clarify for people who don't see the difference between primary and secondary. So primary Raynaud's is Raynaud's that stands alone and there's no other disorder going on. It's just the Raynaud's. Secondary is when the Raynaud's is secondary to another disorder, such as an autoimmune disorder, scleroderma, lupus, something like that. So the primary Raynaud's is fairly benign, right? Rarely leads to loss of the finger. It rarely needs to be dealt with anything other than behavioral changes. But the secondary ones can be more severe and have those other associated problems. Is that a fair summary?
That's a fair summary and generally true. I'm going to have to step back a little bit on the Raynaud's. Primary Raynaud's is just Raynaud's because those people often have a pretty predominant libido. And if it's in families, certain families can have other things tracking with the Raynaud's, whether it's erythromelalgia or peripheral.
Okay.
But they'll recognize hopefully you'll all recognize the familial component.
And the frostbite, chilblains, pernio kind of connection does that always start with some damage due to cold? No, it's not really.
Yes, it does, but it doesn't have to be frostbite.
Okay. But it's kind of a spectrum of cold damage to the nerves, like the little vessels and nerves get damaged by the cold permanently, and then no.
It's not quite that. So there's not a lot of work that's been done on that, but it's actually the arterial wall itself, the nerves to the arterial wall itself do something different in the cold so that it prompts a change in a complement antibody reaction. So it's a little bit of an autoimmune phenomenon that's been set off by the cold. And that's why when the cold trigger comes back, that those nerves then start acting to vasoconstrict the vessel.
Okay. It's a little more complicated. Okay,
Yeah,
thank you.
sorry about that.
Yeah. And the handout that Marie was talking about.
Wait, can I just go back? So
Please.
it doesn't have to be frostbite. Frostbite, you'd have like blisters and your skin's falling off. This cold exposure and Raynaud's can happen just with, say, I'm outside and I have to remove a lot of snow and I feel like I have to do it. No one else is going to do it. I'm going to get this done. And my hands are like blocks of ice. My feet are like blocks of ice that take like a half an hour to thaw when I get back in. That kind of cold exposure is enough to do it.
Okay. We've probably all had that if we've lived in the Northeast long enough.
It's pretty here.
I'll jump in here. Marie, thank you so much. This is so great. And I know that there's so many questions there, and it's kind of it's a complicated topic, I think, because there's so much overlap with such a spectrum of normal and then so many other things that cause this abnormal pattern, right? As you kind of alluded to. So there's a nice question talking about neuropathy and symptoms related to that. And that seems like something that I think a lot of patients would have questions about. So maybe you could just expand a little bit on the overlap there and how you think about it.
Yeah, I was going to actually tell Dara she has a whole nother talk to do after this about dysautonomia.
Yes.
So neuropathy, people are going to get, they could get episodic numbness. They're not going to get the color change by itself unless they get Raynaud's with their neuropathy, which they can. So all neuropathy is not going to have Raynaud's, but neuropathy absolutely can provoke episodes where the digits get a well-demarcated cutoff and they're going to get either white or blue.
And, there's some overlap. I think you mentioned dysautonomia, and I think this group has heard a lot of our discussions about that. So do you want to also comment on maybe some of the features of the small fiber neuropathy? Because I think there may be a number of patients in the audience that are just hoping for a few more pearls from you.
I think that something has changed over the past 5 years where I see a lot more dysautonomia. And the dysautonomia that comes to my attention is when people have display Raynaud's. Sometimes they display that whole spectrum of vasospastic diseases together, very rarely with the lymphedema like that one man did. And sometimes they're the dysautonomia is the reason they actually have POTS. I have to say that treatment is difficult, as we all know. We have many options. Some of the therapies for dysautonomia, just going after the dysautonomia directly along with the lifestyle recommendations for Raynaud's is enough to decrease the amount of Raynaud's. So the secondary Raynaud's in that case is not as bad as the secondary Raynaud's that would happen with scleroderma, for example, or with bad thoracic outlet. So it's a little easier to treat. Dysautonomia can also have a chronic regional pain component to it. So I work with patients to help them separate which part of their discomfort is happening when they're actually getting the white or blue fingers or toes, and what discomfort they're having at different times. And that lets me think about the therapies. Like, am I going to push the therapies that are going to work directly on the dysautonomia versus trying to push a little harder on vasodilating therapies? It is untapped, big population. So I'm sorry for all of you out there, but we are trying to help. Yeah. And I think your doctors in general are trying to help. But people get upset because they don't have a cure yet.
Yeah, very disabling.
Yeah, and I think it's really hard sometimes to sort out all the symptoms. So I think people appreciate hearing, you raise the issue, right? That if it were easy, right, to make this diagnosis and have a clear treatment plan, right, this wouldn't be so complicated. While we're
Allison, can I add to that? The patients can help. The doctors and other people that are providing healthcare are sometimes given these little bits of time to spend with you. It helps a lot in these kinds of complicated situations if you can actually keep a diary of, I felt this in my, I'm just going to use the hands, but can be the legs. I felt this in my hands at this time, and this is what I see. And even if you have pictures and things together, but as much as you can detail ahead of time, it helps them sort it out.
Yeah,
that's great.
Interrupting Allison.
No, I was just going to ask a second, maybe difficult follow-up is, you kind of touched on some of these GI symptoms, and that might be kind of news for a lot of patients in the audience, and I think might warrant a couple more, follow-up details, just in terms, because that's just such a big diagnosis. So when should we be concerned about kind of GI complications or symptoms, in somebody that has maybe this pattern?
So there are particular medications, particularly if they affect CGMP receptors. Amyovig is a huge one that will cause intestinal vasoconstriction.
Amyovig being the new migraine medication.
New migraine medication, thank you. There, the way that you're going to do it as a patient is think about, like, the pain is going to be that kind of, clenching gut pain. Often you will have had coffee or some kind of stimulant that provokes it. And I would, as a patient, try to do something to limit whatever the common reason for my stomach pain would be, which would be talk to my doctors about whether I can take any medication that's going to work directly on my stress response in my stomach. So whether it's Prilosec or something over the counter, or some more milk, anything. And you want to know if that alone is able to make it better or not. And if it's not, you got to see a doctor. They're going to have trouble. They might get a lot of extra testing on you, which if you can tolerate, you might be okay anyway, like endoscopy. At the end of the day, if people have these episodes and it can't be figured out, they are going to end up with someone like me. But if they're episodic and there's clearly some kind of stimulant that triggers it, that makes this more likely to happen. And, deep breathing through those stimulants helps. Stopping your 8 chocolate bars or 75 cups of coffee a day would help no matter what. It's hard to test for, Allison. So I have a crusade that will eventually get a test. But one thing we do is try early in the morning to look at arterial flow in the gut before people have a lot of bowel gas. And we ask you to let us scan the arteries in your stomach and then let you have an espresso. And then we scan the arteries again to see if they're clamping down instead of opening up. eventually we'll be able to do that kind of test with MRA,
Interesting.
but they're not quite there yet.
Interesting.
That'd be hugely helpful for people.
Well, I think it's so helpful to hear how much you are reliant on the diary and for people to understand things that really trigger symptoms, right? And how, just putting those two things together and then avoiding some of these, I think is really helpful, right? In these situations.
Completely.
Yeah, at the very least, to identify and avoid the triggers. And the stress piece of it's so interesting too, because talk about overlap with so many things that we see. Stimulating the sympathetic nervous system can cause so many problems in so many organs. So that it's a good place to start for all of us to try to address that. Somebody was asking for the website for that breathing exercise. It's an iPhone thing, but right, it's just an app that's free.
It's an app that's free, and it's called Breathing App on your iPhone.
Breathing app. And if they don't have an iPhone, probably Androids have the same thing, is my guess.
Sorry, there's a little iPhone shout out. We have a handout we use with patients, and to be honest, other doctors have asked for it as well, that I could send you guys and they can send out. So it could be that same advice about how to use your breathing response.
Thank you. That's great. Okay. All right. We're diving into the questions here. When you're in a swimming pool and your fingers turn white, what's the best thing to do to get the blood flowing properly again? Yeah, there you go.
Put your hands over your armpits.
That'll always be a warm place. And get out of the water. But
yeah, get out of the water. Because you're not going to be able to swim eventually when your hands are going like this and you can't move them right.
Yes, true. Okay. And then, so a lot of questions about red without the white and pain without the red. So
you have to have white or blue. You have to have white or blue.
Okay. So the fingertips are red. Okay. Because white means no blood flow or decreased blood flow. Blue means the blood is there, but it's not getting enough oxygen. Red, right. So many reasons we get red, right? It's more blood flow. So red is more blood, white and blue are less blood. So if it's just that it's red, could be many things, but it's not Raynaud's. Okay. Okay. All right. So interesting. Then there's there's an episode here. Okay. I've had white fingers and toes for the past 65 years and manage a very active life. In the past 6 years, I've had several episodes of angioedema. So that's systemic allergic reaction where people often get hives and swelling, right? And generalized urticaria, that's hives, in warm months, not at any time when having Raynaud's. Is there any known link? So you're talking about like histamine release, allergic reactions. Is that related in any way?
No. That's a good one.
Okay. So common things are common.
Actually alluded to it because they're getting the histamine release in the warm weather and the Raynaud's in the cold weather.
Okay.
And there's some overlap as you go warm to cold, but they're not.
Okay. Great.
My first easy question in decades.
And so someone else was asking, what kind of doctor should they see if they think this might be going on? Just start with a primary care doctor or start with a vascular doctor, a cardiologist, a surgeon? So to be clear, Dr. Gerhard-Herman is a cardiologist and a vascular specialist within cardiology. There are vascular surgeons who typically operate on blood vessels and vascular cardiologists who treat them medically, who treat blood vessels. So vascular refers to the arteries and the veins of the body. But it's kind of these symptoms can be they can be nerve, they can be blood, they can be pain, so many things, right?
So at the risk of never being invited back again, people just need to see a good doctor, a doctor that's actually going to listen to what you're telling them. This is so, particularly for primaries, this is so prevalent. There would be no way that vascular medicine providers could see every person with Raynaud's. We're happy to see anybody, to be honest, but many primaries can be very good at this. And the only limitation that sometimes gets imposed on them, to be honest, is that they're restricted in how much time they can spend talking to you. So that's why I think that the diaries are very helpful.
Yeah.
And they give people a leg up.
Right.
And vascular surgeons, God bless them, will send the patients to me.
Good.
They recognize that it's Raynaud's, but they're still going to send the patients to me.
Well, I think it's just so helpful to hear your focus on symptoms too, because I think that's really empowering for a lot of patients. I mean, certainly the cases where there's really a question of if there's something secondary causing it, right? But for a lot of these symptoms, your approach to the treatment might be targeted kind of the same, right?
Yeah, exactly. Exactly. And isn't that why we're here, Allison, to help people feel better?
Yeah, absolutely. I mean, I think, education is very powerful, right? And there's a lot of questions as to the what if, and if we kind of address that, right, and take away some of that stress, right? I mean, it definitely helps everybody to live with symptoms that they have, I think.
Great.
Okay. I am looking through for any other questions.
I'm answering a couple in here. So again, pain without discoloration is not Raynaud's. That's another question here.
You actually have to have discoloration, and that, yeah. So I didn't show you the pictures. Shoot. So that is going to be dependent in part on what your baseline skin color is.
Yep.
So I think it's one of the rare cases where the really pale people, it's sometimes more difficult to see. So sometimes taking pictures of your own hands and just seeing if there's a demarcation helps. And in the people with dark skin, grades of dark skin, it's not going to get white. It looks more ashy. And that was a sad phenomenon that I noticed during the beginning of the COVID era, was that people had these ashy toes that weren't getting attended to and ended up having gangrene. It turns out that they had vasospasm, which is not watching. And if someone has that primary vasospasm and they have very dark skin, it truly might not be picked up because people aren't thinking that it's a well-demarcated change.
Interesting. Yeah, you coined the term COVID toes, didn't you?
Yeah.
It turned out to be a big thing. All right, I have a question for you. So a lot of our patients take medications called beta blockers, and that would be metoprolol or tenolol. You know what I'm about to say, right? For various reasons, atrial fibrillation, high blood pressure, coronary disease. And at least 50% of them will say, ever since you put me on that medicine, my feet are always cold. So what would you say about that? And is there any getting around it?
The only getting around it is to switch them from any of their beta blockers to something else. And if they need some component of beta blockade, carvedilol has beta and alpha, so we use that. They are notorious for causing Raynaud's phenomenon to rear its head. And the person might have even been perking along with a little bit of primary that never really bothered them, but then you can see it when there's a beta blocker added. With respect to one thing is, for the patients, it's not usually as bad as the Raynaud's phenomenon that gets triggered with something like Adderall. So I find that very interesting. And it is, yeah, I think in those cases, it actually usually bothers the physician more than the patient when it's a beta blocker triggered secondary Raynaud's phenomenon. But we have an option, which is switching to carvedilol.
The carvedilol, or if you have to, a calcium channel blocker, right?
That would be great if you can do it. The question is, why are they on the beta blocker in the first place? Yeah.
Okay. Another question about neuropathy. A couple of people are asking about neuropathy. So someone asked, what's the difference between Raynaud's and neuropathy? How are they visually different? And someone asked, will neuropathy on a foot or toe be more susceptible to Raynaud's? And is there a way to resolve that? So neuropathy for everybody is when the nerve is damaged. So nerve is disease of the nerve as opposed to vasculopathy, disease of the blood vessel.
Yeah. So it's pretty straightforward. You have to have well demarcated blue or white fingers or toes for there to be Raynaud's. So that's the difference in appearance. Does having neuropathy cause Raynaud's? Yeah, a little bit, not always, but if we can treat the neuropathy, we usually make the secondary Raynaud's go away. So the neuropathy doesn't cause a structural change in the arteries, but it changes the way the nerves receive the signal to whether to open and close the arteries to the toes or fingers. Was there a fourth question in there?
No, I think that's kind of it. And then does it cause lasting damage? I mean, I think of this as a reversible problem, and someone was asking if they have recurrent Raynaud's, is it going to cause, say, difficulty walking as they get older?
Oh, that's a good question. No, and no, but there's another level to that. So no, it doesn't cause any lasting damage. So if I periodically have white fingers and then I warm them up and my fingers are normal color, there's no damage to the fingers. There is a question in my mind always about if people have lots of episodes of Raynaud's phenomenon. There are different hormones that are sent out in your body. When we think about this with the heart, when we think about ischemic preconditioning, there is probably something that's happening all over your body when those local signals change because they're carried around through the bloodstream. But there's no ongoing structural damage to the fingers that we can tell. But
That's
for
great.
goodness sake, if you have Raynaud's all the time, it's very uncomfortable and you can't do what you need to do. So someone should probably help you with it.
Thank you.
Marie, do you want to comment about exercise and particularly its role, as you're focusing on increasing blood flow, diminishing symptoms, working on stress?
Exercise is totally key. Totally key. I actually was deciding whether to change into my running clothes before or after this talk. So the thing with exercise is that when you exercise, and exercising can be something as simple as walking. And I try to get people to walk for up to 30 minutes a day, but there's increased blood flow down the blood vessels. And you have various vasodilators that are secreted, and they're incredibly helpful to your heart, to your brain, and to your fingers and toes. So I do have everyone exercise. And if we're talking about exercising and it's cold outside, then we talk about all the secondary ways of preventing yourself from getting cold, whether it's the gloves with heaters in them or just glove liners and boot liners. And if necessary, I tell people to find an inside place to walk or to use a treadmill or a bicycle, but it's incredibly helpful.
Yeah, we spend a lot of time talking about exercise on these sessions, so I just wanted to make sure that we tie it all together. Just the many.
I have to comment on that because you spend a lot of time talking about it. I spend a lot of time talking about it. When I'm out, I see people that are out. But then when I look at the data, particularly when I was looking at the PAD data, the number of people that don't walk more than like back to the mailbox, back and forth to the mailbox a couple times a day kind of walking is huge. So I don't think we can stop talking about exercise.
Yeah, we'll keep talking about it. I have a question for you about estrogen. You mentioned that estrogen levels can fluctuate and cause this. So of course there's perimenopause, menopause, menstrual cycles, and then there's also birth control pills and hormone replacement therapy. Is estrogen a vasodilator, vasoconstrictor? Is it the fluctuation? Is it the level? How do we think about estrogen and Raynaud's?
Estradiol is a vasodilator. So if someone had been really having primary Raynaud's and it was annoying to them, and then they get pregnant and they have high estradiol levels all the time, they won't have Raynaud's. Estradiol in its purest form, what you secrete, or like a patch estradiol is the most potent in vasodilating. The shifts in estradiol level, particularly if someone has secondary Raynaud's or primary that was barely noticed before, are important because you get arterial dissections with big shifts in estradiol. So those would be those are big shifts of some sort or another. So not typically the off and on of a menstrual period. So your Raynaud's can fluctuate with those estradiol levels, but it's more like something that is a more potent estradiol signal coming on or going off quickly.
I see. Okay. And can you ever use, say, topical estrogen here to prevent Raynaud's in the hands? Does that work? We don't do that.
We don't do that.
Patch doesn't work that way.
No.
More systemic.
More systemic.
Okay.
Actually, if you put a patch on, it's going to become systemic.
Okay.
A
Yeah.
lot of, for everybody out there, there's a lot of topicals that can be used if we need to. If there's a reason we can't use things that we're going to have you take. The issue with the hands, clearly much more than the feet, is that if you have goop on your hands, like how can you do things?
Stuff like nitro paste or topical lidocaine. You're thinking of the ointments and pastes that we could use.
Yeah, there's a lot more than that. If you have to put on your fingers, you use white gloves. But the nitro paste for everybody is a little bit of it could be a lifesaver because it can open up arteries right away. But there are two things. One is it has a systemic effect and it'll lower your blood pressure. And the second is with nitro paste, people get nitrate tolerant. So it's not a long-term anything for us.
I see. Okay. All right. Allison, did you have any more questions here?
Well, I think there's another question that just came in talking about tamoxifen. And I think, that's something that we see, a lot of use just because of the prevalence of breast cancer. Are there common things that we should know about that predispose to symptoms?
Tamoxifen does tilt the response towards clamping down rather than opening up, but it's been hard to sort out tamoxifen's impact away from breast cancer, because breast cancer itself is a reason for secondary Raynaud's phenomenon.
This person said after they stopped the tamoxifen, the Raynaud's seemed a bit worse. So interesting.
Oh, interesting.
Yeah.
It's very interesting by itself.
All right. We have one final question, then we're going to wrap up. Is it all autoimmune diseases, including Crohn's disease, or is it just specific autoimmune diseases that are connected to Raynaud's?
I would like to say it's specific, but I can't. It's all autoimmune diseases.
So, and it's just that the autoimmune process where the immune system is attacking the body, attacks those little nerve endings on the blood vessels. So any autoimmune process can do that.
Yeah.
Okay. Unfortunately. Okay.
Very unfortunate.
Great. So Marie, thank you. So you've taken us across the entire spectrum of blood vessel problems and how they interact with the nerves to cause white, blue, red, pain, swelling, sometimes from a cause such as an autoimmune disease or exposure to the cold or a medication, and sometimes just primary.
Yeah.
And out of the blue, and kind of depending, it sounds like the primary ones tend to be more mild. The secondary ones can be more severe if it's secondary to something like scleroderma, but milder if it's secondary to dysautonomia, at least from what we've seen, although.
Or beta blockers.
Or beta blockers. Yes. So still research being done and hopefully more answers coming up down the pike, thanks to people like you who are studying this. So I want to thank all our audience for coming. And Marie, especially thanking you for, I know how busy you are to take the time to answer our questions. And we're going to send out to all our audience some of these handouts that Dr. Gerhard-Herman is talking about.
I'm going to do another one right now for the stress response, because that'll help
Oh, good.
people.
Thank you.
Friends.
Yay. So the moral of the story is exercise, reduce stress, and follow
This is actually water. Drink water.
drink water and warm water if you have Raynaud's. All right.
Right, warm water is actually incredibly good if you have Raynaud's.
And just holding the mug, even if you don't drink it, right?
Holding the mug, yep.
All right, thanks. Our next webinar is actually going to be on November 6th, and it's at 4 p.m. instead of the usual 2:30 p.m. Dr. Amit Anand is going to be talking about pranayama and breath work. He's a pulmonologist at Mass General, so definitely tune in for that one, and you'll see something in your email about that. Thank you, Dr. Gerhard-Herman.
It was a
And thanks,
pleasure.
everybody.
Thanks, guys. Bye-bye.
Marie, bye, everyone.